To be here, and I can't tell you how fun it's been to be involved in this SIM group that is really working hard, I think, to make a difference in Rhode Island for the serious needle population, who is my personal passion. So my job is advanced care planning, who, what, how, and why this morning. So I think what I really want to get across about advanced directives is that it is not a one and done kind of a thing. It is not, we're going to do this today and we're done forever, because guess what? Things change. Diseases change, people change, life circumstances change. So I would like for you to introduce you to the idea that it's kind of like laundry, right? You do a load, and then more appears in the basket, and you have to do another load. It's a process. It is not an outcome. You're never going to get it all the way done, right? So just thinking of it that way, I think, is really, really important. And again, it actually says it in the definition. It is a process by which a patient with capacity can plan for healthcare decisions in the future. And it actually does matter. We're going to talk a little bit about that. Just so that you guys know why we are here, only a third of adults have completed an advanced directive. This is nationally. We don't really know what Rhode Island data is because it's really hard to know, right? It's diffuse. It's not currently on an electronic platform. We don't really know. But this is national data that was published in Health Affairs in 2017. So only about 40% of people with a chronic illness have one. So that's all comers. But even in the serious deal, the numbers are way lower than we would hope that they would be, right? About 56% of adults have talked to their family about this. So in other words, about 40% have not, leaving their family to wonder what they want done when it all hits the fan. Less than 1 in 4, 13%, have actually discussed any of this with their healthcare provider, which is really amazing, right? That only about 10%. And that 46% of healthcare providers say they don't know what to say when they are tasked with discussing advanced directives with our patients. So there's plenty of room for improvement here, I think, folks. I wanted to show you all 3 documents. They're in the handout, they're in the materials that were sent out, and I just want to introduce you to these. These are the ones we teach in our complex care training, and these are the ones that I typically use. So I just want you to have at least seen them. This is the form. It lives on the Rhode Island Department of Health website, the Durable Power of Attorney for Healthcare, and all that it does is allows you to appoint a Durable Power of Attorney for health, okay? That's it. Not that that isn't important, but that's what that form does. Anybody can use it as long as you are competent, over age 18, and a citizen of Rhode Island. You can use this form. It's free, it's fast, it's fun. Everybody in this room, if you have not done it, please do it. Please go and appoint a Durable Power of Attorney. Because as Jay said last week, we are not a hierarchy state, and so if you haven't named an agent, it turns into a free-for-all, okay? So please do it. It's really, really important. This is kind of what I call the next step. This is the Durable Power of Attorney for Healthcare, a Gift of Preparedness. This form used to live on the Department of Health's website. They took it down and put this form up instead, because this form is a little more, if I can use this scientific word, squishy. In other words, this form allows you to sort of say, I would want my life to be prolonged as long as possible. I would not want my life to be prolonged as long as possible. If I were in a vegetative state, I would want X, Y, or Z. If I had a malignancy and I was not likely to get better, I would want X, Y, or Z. So this allows for some future sort of prediction, if you will. You know, gives you a scenario and allows the patient to respond to that scenario. It also allows for organ donation, if you want your chaplain called, et cetera, et cetera. My favorite part of this form is actually the page at the very back, which is a blank piece of paper with lines. I have in my travels around this state with seriously ill patients seen that used in a beautiful way at times. I've had a patient, she was in her late 90s, and she wrote a letter to her healthcare team on that thing. And she basically said, if you're reading this, there's something that's drastically wrong with me, and I probably can't speak or make my wishes known. Let me tell you about me. I hate TV. Don't put me in front of the TV in the nurse's station. I hate bingo. I'm private. I want to listen to classical music. I want to look at trees. I want to stay in my room by myself, blah, blah, blah. And she really laid it out. And again, I think people tend to think of advanced directives as like DNR or not. This was a beautiful advanced directive that allowed us to exquisitely care for her in a way that really made sense to her, right? She told us who she was and what she did and didn't want, and we were able to then tailor our care to her. So this form is valid, as Jay taught us last week. It's 12 pages. The downside of this form is if you give it to a patient and a family, they're going to put it in the trash, right? Who wants to sit here and think about whether you're in a vegetative state and navigate 12 pages on their own? So my suggestion is if you're going to use this form, this needs to be an assisted form. Somebody in your office, whether it's a nurse, a social worker, a medical assistant, needs to sit with a patient and a family and help them with this form. It's too intimidating to take on all by yourself, okay? So that's a great form because it allows people to plan and to come up with scenarios so that if they fill this out and the poor agent doesn't have a clue who they are, this form will help them fill in those gaps, right? This form didn't copy well, but you all have all seen the pink MOLS form, and that is the form that we reserve for seriously ill patients. Unlike these two patients, which state wishes and preferences, this is a medical order, and therefore will absolutely limit care. This form is something that when you get to the hospital, Dr. Bledsoe can write the DNR based on this. This one is a DNR, so that when EMS arrives to your house, they will not do certain things if you don't want it done. Okay, so those are some of the forms. There are lots of other forms. The reason that I teach these and use these is because they're free and they're available online. There's plenty of other advanced care documents out there. Many of them, though, are branded and proprietary and you have to pay for them. I'm all about free. And none of these have to be taken to an attorney. All of these, this one is just signed by a physician, a qualified healthcare provider, and these two, as long as they're signed by witnesses, as we talked about with Jay, they don't have to be, you don't have to go to get your estate done and cost a ton of money. They're very easy to use, which is the other reason that we recommend them. Yes, sir?
Two quick questions.
Yes.
The middle form still has legal standing in Rhode Island?
It absolutely
does.
does.
It wasn't supplanted, even though it was taken down?
It was not supplanted, no. And the Department of Health just felt like it was a little too squishy to be sort of on a regulatory website, but it's actually on our website at HopeHealth, and it's on the Rhode Island Cancer Society website. You can still get this form.
And I've been told, but maybe it's not true, that most, you can't use it unless you've declared terminal and like hospice for you.
Right. I'm glad you asked that question. So in fine print at the bottom of the MOLS form, it says to be used for people with a terminal illness. To me, there is a difference in somebody who is living with an illness that will be terminal and in somebody who is the hospice definition of terminally ill. Most states use the surprise question to decide if they're going to use this form. If you would not be surprised if a patient died in the next year, you can use it. It's certainly not a form to be used in well people, but my feeling is if in your medical opinion this patient doesn't want these interventions and they aren't going to be beneficial or helpful to them, this is perfectly legitimate to use. They need to have some kind of a serious illness, and they use the terminally ill thing to match all the other end-of-life legislation that has heretofore been passed in the state. Yes?
If somebody does not have a terminal illness and has that form, does that make it invalid?
Not the lawyer. I have certainly used this form for 95-year-olds, otherwise well, because my feeling is they're not going to benefit from having chest compressions and CPR. I think you have to use your judgment. I have certainly used it in patients with earlier stage dementia who are not yet terminal, but they have an illness that is going to be terminal, and they don't want these interventions. So I think you have to use a little bit of your clinical judgment. It's certainly not a form for 50-years-olds, but in patients who you really don't feel like could benefit from whatever intervention there is, I feel very comfortable using it. It's what it's there for. Does that help?
Yeah, the reason that I asked is that one of the providers that I was working with says that she's using it for all of her patients now because it's so simple and they can put it on their refrigerator and it's bright pink.
Yeah.
But perhaps that's not the
I don't think that's the way that it was intended to be used. It really is intended to protect seriously ill adults from unwanted medical interventions.
Probably if you're thinking about putting a DNR tattoo on, it would be preferable to get the pink form on the fridge.
You're probably right. Exactly.
As a licensed EMT in the state, if I walk in and I have one of those in my hand and matches the patient's name, I'm following it, whether they're terminally ill or not.
That's exactly right. Because the onus is on whoever the healthcare provider is signing it, feeling like in their medical judgment, this is an appropriate path to take at this moment in time. Yes?
Just to clarify, to the previous discussion, you said the MOLS is a legal document, or it's a medical PHI.
Yes.
So you should not upload that to the website.
I'm going to hold the upload questions for now and just get through this, but I definitely will come back to that because I don't know where we are with that question.
We can talk about that.
Okay. All right. So, again, just for the information for the providers in the room, you can actually get paid for this. And on the back of this serious illness, for anybody who went to the CTC Collaborative, this is a handout we used. On the back of the handout, it gives you at the bottom the 2 codes that you can use. This is Medicare's rules, not mine. Please don't ask me how they decided to do it this way, but this is what we have. So Medicare sees this conversation as a procedure, and it has given us a procedure code that can be used in addition to other billing codes to supplement the time that you spend doing advanced care planning with your patient, regardless of whether they're healthy or seriously ill. It's billed for a 30-minute block, so you have to go 16 minutes, because you have to get halfway through the 30-minute block, don't ask me why, and then you can use the 99497. And the average reimbursement for this is actually pretty significant, $82 for the first 30 minutes that you spend advanced care planning. If you go longer than that, you then have to go to 46 minutes because you have to get halfway through the second block. And then that will give you an additional 72. If you bill for more than 46 minutes, you have to use this code and this code. And if you then go on for an hour and a half, I would argue that you're probably wasting your time at this point. But if you do, you would say, you would do this one again. So you can use an unlimited number of these. Now, Medicare is probably going to audit you if you've got 6 of these suckers on one billing code, right? But you just need to document why it took you the time that you did, who was in the room, the time you spent doing it, and what you discussed. That's really what's there. And there's a small template on the back of this if people are interested in sort of what that would be. Any questions about that? This is Medicare. Not all payers are paying for these codes yet, just so that you know. But at HopeHealth, we tell our providers, bill them, and our billing department will figure it out, because we don't want to leave money on the table, right? So that's how we have been doing this. Okay, so where do we even start with this whole process? So I'm a simple caveman, and I like to look at advanced care planning like ice cream. There are 3 patient flavors for advanced care planning activities, in my humble opinion. Chocolate, vanilla, and strawberry, okay? So vanilla is kind of boring, sorry guys, but it's boring, right? They're healthy people. So the focus really for healthy people should just be planning for a disastrous event, right? We don't expect that for an 18-year-old, they're gonna have any medical issues. But God forbid, they literally get hit by a bus. Who would they want to make their healthcare decisions for them, and what would they want is really the big thing. So planning really for a catastrophic event. Also, if you are taking care of young, well people, making sure that you occasionally recheck who they've got for their agent, because especially early in life, your life circumstances change a lot, right? You appoint your college roommate, now he's over in Taiwan, you're living with somebody else, you've got a girlfriend, you've broken up. That person's still your healthcare agent, so making sure that you're checking that frequently and getting the form updated. And then, and this is really important for these young people, because they write it down, they ask their college roommate one night after a party and they put him down, and the college roommate had no freaking clue what this person would actually want, right? So it's really helpful too, if you have a young person, to maybe go through some of the, what makes your life worth living, what would you not be willing to do? But that's another level that you don't, if you can just get an agent appointed, you're doing a good job, right? Although unlikely, and this really is how I would recommend saying it, although unlikely, who would you want to make your healthcare decisions if you were hit by a bus, had something catastrophic happen? And then this is, I think, worth exploring, because again, so often agents for very young people really don't know what they would want and what they would be willing to live with or without, right? Would you be willing to live if you could not move your arms and your legs? Would you be willing to live if you had to stay on a respirator? Those kind of questions. So is there any ability you could not imagine being alive and not being able to do? That sort of line in the sand, right? If I can't do this, I don't want you to keep going with whatever. And then is there anything that you would want your healthcare team or family to know about you? Again, that's where that letter from that 93-year-old is really helpful. You know, I really hope that you will keep me covered. I really want to have my dog, whatever it is that is kind of the extra stuff that really allows us to care for people in a meaningful way. So again, my recommendation is that durable power of attorney, download it off of the Rhode Island Department of Health website and get them appointed. And then if you want to do a little bit of exploring with them in terms of what abilities are so important to them that it would really change how they think about healthcare, the gift of preparedness, that 12-page, or the 5 wishes, which is a branded document, can be helpful to explore that and empower their agent to really make better decisions. Any questions about vanilla? Pretty easy, right? All good? Okay. Ooh.
I have a question, Jen. Like, do you have, like, one of the things that folks are trying to look at is what's a good time to do this? Like, would you recommend, like, points of transition, like going to college, or, the beginning of the decade? Like, is there any kind of, like...
I think that's a great question. I would say when people are 18, honestly, I feel like at that 18-year-old well visit would be a great time to just say, guess what? You're an adult now. It's time for you to think about that your parents don't necessarily de facto make your healthcare decisions anymore. Who would you want to make, blah, blah, blah. And then again, I really do recommend, especially in the early 20s, that document gets looked at fairly frequently, because that's the time of life when people's social circumstances are changing so much and their agent changes at times, because it's their mom, and then it's their boyfriend, and then it's their fiance. Once people are kind of settled, usually, and married, obviously without a divorce or something like that, they tend to stay the same. But I really do recommend, I think this is a really important part of well care of younger and healthier adults, whether it's, just a quick look at the annual visit, just making sure you have your college roommate named as your agent. Is that still who you would want? I think that it would flow very nicely there. Again, this doesn't take very much time in these people because they're healthy, right? You just want to make sure they've got somebody who can make decisions. Is that helpful? Yeah. Okay. Now we're going to talk about chocolate. And the reason I call this part of the population chocolate is because there's all different kinds of chocolate, right? There's German chocolate, there's milk chocolate, there's dark chocolate, there's Swiss chocolate, there's chocolate with almonds, all different kinds. And so chocolate are people who are sicker, who are not at the end stage, but are that kind of amorphous population of not perfectly well, but also not ready to sort of have really serious conversations about their illness. And so this is a little bit more heterogeneous group of people, if you will. But just to kind of think about this. So, for example, a new diagnosis in an otherwise healthy person of a condition that may be progressive or chronic, such as COPD, renal failure, dementia. Even in a well 70-year-old, they've gone from really somebody with no medical issues to suddenly having something that you as a healthcare provider know is over time probably going to progress. I would argue even hypertension and diabetes, right? That this becomes somebody who is living with a chronic illness, right? Or worsening of a chronic condition. Again, these are chocolate, where they have a little bit of renal failure and they come back in the office and the creatinine has doubled and you're like, These people are chocolate, and it's important that they flag our attention because it's a real opportunity to have a meaningful conversation with them about their specific illness. So unlike vanilla people, who all we really care about is a catastrophic event, these people have something that is going to make them more at risk for badness, right? Whatever that badness is. So I always recommend for these people, if at a new diagnosis, as the condition progresses, before elective or high-risk surgery, make sure that this is done so that, God forbid, if something does happen, they're protected. And then regular conversations, and I think this is where sometimes we don't think about this as advanced directives because it's not deciding about DNR or feeding tubes or those kind of things, but this is part of what our patients need to help them plan. Your creatinine has doubled, and here's what we're going to do. We're going to do this. We're going to send you to a renal doctor. We're going to this. There may come a time when you may need dialysis in the future. And again, saying it early so that people have time to think about it, to get information about it, to adjust to it, and to maybe make the decision, no thanks, that's not for me. But if we don't do these things early, people don't have time to plan. And people don't have time to adjust, and that is a huge part of advanced care planning, right? Because I might say, I want everything done, but if I don't really understand what that means, I'm not making an informed decision, right? So it is these check-ins all the time with our chocolate patients. This is where you are. This is what end-stage dementia looks like, and this is where we are headed. And again, I wouldn't say it that way, obviously, but that's our job, is to really be proactive and help people plan and understand. So, for chocolate, my suggestion is everybody who's chocolate certainly needs to have a power of attorney for healthcare. We've already established that that's our baseline, right? They've got to have somebody who can make their decisions. And then a deeper discussion around issues that are likely to come up with a major illness. And I liken this for people who do pediatrics, I liken this to anticipatory guidance, right? You say, okay, you're getting ready to be a toddler, so make sure that the outlets are protected, right? So you want to talk to them about what is likely to be ahead with their condition so that they and their families can plan and prepare and face it sort of meaningfully. So again, if they've got dementia, talking about feeding issues down the road, talking about intubation if you've got a COPD patient, right? What you talk about is going to be specific to the person and their illness because it's what you predict is likely to be ahead. Does that make sense? I think another great way to sort of talk about some of these things is this a curable disease versus a treatable disease? These are some words that can be helpful. Time-limited trials, right? We're going to try this, we're going to do this chemotherapy, and if it doesn't work, we're going to do X, Y, or Z, right? Helping them and making sure that they know you're going to be along with them as things change. And then remembering to update whatever they actually want as far as advanced care planning as things progress and change. Does that make sense? Chocolate. So this is the Institute of Medicine Serious Illness Model, and I just want to be clear that maybe the chocolates are down this way, but at some point people have a condition that is really likely over time to become terminal, right, and lead to end-of-life situations. So it's a little gray when people transition from being chocolate to what I call the strawberries, right? We could argue about where that would happen on this illness. And so there is a blurring, if you will, between people who are chronically ill and acutely ill to people who are seriously ill and terminally ill, right? And we could all argue about where that line in the sand comes, but that's sort of where we are. So again, for our chocolate patients, I like these words to sort of open. I want to give you the best possible care, and I'd like to talk about that with you now. Would that be okay? If you get sicker and can't make decisions, who knows you best and can help your team take care of you in a way that makes sense to you? I see you went back to the hospital again with heart failure. Would it be okay if we talked about how things are going and what is likely to be ahead, right? Kind of really aligning with the patient. I want to do what's right for you. Would it be all right if we talk about this now? I have never been turned down when I ask patients this way. They're usually quite relieved that somebody is noticing that things are not going particularly well and are happy to talk about it. So those are great openers as far as I want to take care of you in a way that makes sense to you. Would it be all right if we talked about that now? And if they say no, then the answer is no. Then the next question is, okay, then who can I talk to? Can I talk to your daughter? Can I talk to your spouse, right? But certainly those are easy ways to kind of ease into it. And again, I would argue that these chocolates, once you've gotten their durable power of attorney appointed, you're going to know the chocolates because they're the things that when you open the chart, they make your heart sink, right? The creatinine's worse, they're back in the hospital, they've fallen, they've lost 10 pounds. It's probably time to have a conversation, right, at that point, and update what we think is happening, and then perhaps make changes to the advanced care planning documents, but having a meaningful conversation about where we are with the illness. Make sense so far? We good with chocolates? Okay. So again, for chocolates, I certainly recommend the durable power of attorney for health. I recommend the gift of preparedness because that allows them to flesh out those conversations around, do I want to be on breathing machines, do I not? I put 5 wishes in parentheses because you have to pay for it. If you want to pay for it in your practice, it's about $1 a copy. It's not hugely expensive, but it is an expense. And then depending again on the patient's preferences and kind of how chocolate they are, some of these patients may actually qualify for a MOLST as they sort of head into more significant and serious illness, especially if they don't want aggressive care. And I want to say one other thing about a MOLST form. If you're getting ready to fill out a MOLST form that leaves a patient a full code, do everything, please don't waste the ink. And please don't confuse David's team when they walk into the apartment and they see a MOLST form and that causes them to delay care to your patient. The default in the state of Rhode Island is do everything. So if your patient wants everything done, they don't need a MOLST form. They only need a MOLST form if you're going to limit the stuff that's happening to them. Does that make sense? It's just going to confuse things and delay care. And if your patient, please tell them as you fill these out, if your patient changes their mind, they just need to throw the form away, okay? Rip it up and put it in the trash can before the EMS gets there, okay? Questions about that? Okay. Strawberry, my favorite flavor. The seriously ill. Certainly, our strawberry patients are our highest priority from a population health perspective, right? These are the ones, 13% of these people have even discussed anything with their families. Only about 48%, I think it's less than that, have even thought about advanced directives. Less than half of them have talked to the family, and these are people who are really, really sick. So we have got to, first things first, make sure that we are taking care of these people so that we are giving them the goal concordant care that we all want to have, right? That we are doing for them what they want, no more, no less. So, I love this quote. This is Mimi Patterson, who's a palliative care physician. She says, if you would not be surprised if your patient died in the next year, please don't let them be surprised. And don't let their families be surprised. So that is a great, great question, which we're going to talk about a little bit more. Again, all of our good chocolate skills as diseases progress and as things get worse and before elective surgery are all absolutely indicated, and then there's some other skills which we're going to talk about. So again, these are for sure are seriously ill and heading into terminally ill patients, right? These are people who we expect may not be alive in a year from now, okay? So maybe not by hospice definition terminally ill, 6 months or less, but maybe here, right? These are really, really ill patients, okay? So I think this is really helpful because so often providers say to me, I don't even know who I should be talking to. I found that during my internal medicine training, I got so numb to illness that I didn't even know who was sick. I never saw a healthy person. So everybody walked around with class 4 heart failure or renal disease, and what do you mean? But of course I was only seeing a tiny, tiny section of the population, and I think sometimes we get numb like that too. We see our patient and they've got their 15 different diagnoses and we're numb to it. We don't realize, oh my gosh, it's kind of like not seeing your own children growing up, if you will, right? We get kind of blinded. So this is from Bernanke and Susan Block, who published a paper trying to help us, who do we need to talk to? So this comes from the Ariadne Labs, and this is their publication from JAMA in 2014. 5 really significant groups of people to talk about. Solid tumors, so cancer, either with metastases, with hypercalcemia, or spinal cord compression. If these people don't have something in place, they really need to, like yesterday, right? Class 3 or class 4 heart failure with 2 or more hospitalizations. These are people that we need to talk to. CKD on dialysis who are 75 years or older. These are people who do not do well on dialysis, and they need to know their options, and they need to know that if it's not agreeing with them, that they can stop. And what would they want done if that was the case? COPD on home oxygen with an FEV1 less than 35% of predicted. Severe COPD. And then this one didn't project well, but I put this one in red because I think that it kind of doesn't matter what you have. If you as a provider in your gut say, wow, I would not be surprised if Mrs. Jones died in the next year, you need to put the phone down and act on that. This is an amazingly powerful statement that has been validated over multiple diagnoses, over multiple disease states. Believe it or not, in the UK, if you come into the emergency room and you need intensive care, and the intensivist assessing you in the emergency room would not be surprised if you died in the next year, you don't get an intensive care unit bed. You get a comfortable bed up on the medical floor, and they make sure that you're comfortable. This is the screening question for most. This is an amazingly powerful question. It seems so simple. But I would encourage you to ask it, and when you get that answer and you get that gut check, do something about it, because these people are not going to do well over time, okay? And we want to really make sure that we're catching them. Any questions about flavors, how to identify a strawberry? I used to joke with the residents at Roger Williams, they'd be like, Dr. Ritzau, I've got a chocolate patient. I'd go up there and I'm like, this one is a strawberry. This one is a strawberry. So we think of this often way too late, unfortunately. I talked to you about this already, surprise question. I just want to show you, hopefully people got this. This is a conversation guide for, and this comes, again, this is not my work, this is out of the Ariadne Labs collaborative. So this is a script for how to have a very time-efficient conversation with maybe late chocolate and strawberry patients. And I'm not going to belabor the point here, but it works really, really well. This is a different format than we teach in complex care, but it kind of doesn't matter how you get there if the outcome is the same, right? So it goes through, and actually at Dana-Farber, where they're using this, believe it or not, the provider says, I want to have a really serious conversation with you. I've brought my check sheet in so that I know that I'm covering all the bases, and literally they are cued to use this as a scripted tool, and patients don't mind, because they know you're trying to do what's right? And I really want to make sure I've gotten everything, blah, blah, blah. And then on the back of this, just for people's reference, is what they recommend for you, after you've had this conversation, what they recommend for sort of a template documentation, especially if you're going to build those codes, so it's right on the back. And I actually, I made this part up, but using a template that they recommend, I sort of filled in some color commentary. And then, again, in order to make this happen, it's got to be sort of part of the regular practice. And so one of the things that Ariadne Labs is doing is a really cool thing, which is in the morning, the medical assistant comes in and says, Dr. Bledsoe, here's your patient list. You know that serious illness conversation we had? Can you identify anybody on that list that you might want me to set this up so that you can have this? Because the reality is, in a busy office, that's never going to happen, right? Unless we set aside a time to do it. And so what many practices are doing is setting aside a separate visit for a patient to come in with their loved one to have this conversation. Because if you're planning to do it and also address their diabetes and their this and their that, it's never going to happen, right? So he says, yep, you know what, Mrs. Smith probably needs one, not Mr. Jones yet, but blah, blah, blah. Then the medical assistant gets on the phone and says, Mrs. Smith, Dr. Bledsoe would really like for you and your husband to come in. He's really worried about how things are going and would really like to have a conversation. That patient and family is prepared to now come in and have a different kind of a visit than just what's your blood pressure, how's your diabetic neuropathy going, right? They're primed, and they probably got their significant other with them so that they're ready to have it. So it doesn't waste people's time. They're setting aside 30-minute blocks. People run through this conversation guide, run through the other thing, and if it comes up, filling out appropriate advanced care planning forms, billing, because it's billable, and it works pretty well, actually. That's how they're systematizing it with these seriously ill patients, because that's a really, really important part of it. And just so that you guys know, all of those patients, just for your information, are hospice eligible. So if you're having conversations with those strawberries and saying you don't want X, Y, or Z, it's also really important to give them the supportive services that they need if they qualify for it, so that they can stay home if in fact that's what they want to do. That's the conversation guide. Any questions about the conversation guide or sort of how to operationalize it in your practice? Yes, sir.
Can you talk a little bit about incident 2 billing?
I don't know if I know what incident 2 billing is.
Incident 2 billing is when the doctor orders the conversation to happen, a nurse care manager or a licensed staff would have the conversation with the individual, with having the doctor in the conversation.
Right, so in primary care, these codes can also be a team sport. The only thing is, if you are a nurse or a social worker and you're going to do that, you have to have a collaborating physician. But Medicare has recognized that it might not be worth my time for a whole 30-minute block to sit with the patient and the family. So some of this can be done by a non-billing provider in your office, so long as some of the time is spent with the physician doing some of that, and then the whole time that is spent, whether the medical assistant, I probably would do the medical assistant, but let's say the nurse in the practice spends 18 minutes, and then I come in and spend another 12 minutes, just maybe talking about the medical piece, doing the advanced care documents, et cetera. That is all of that time is billable. Thank you, I just didn't know it's called incident 2. But it's only in primary care. You can't do this in a hospital. You can't do it in a dialysis center. It's only in clinic not just primary care, but clinic outpatient settings. Okay? Good? I talked to you about the sample documentation. And again, for these strawberries, it's really, really important that, and it's so delightful to me that the MOLS form is pink for strawberries, right? It's pink because it's recognizable and it's easy, but the pink is, again, if you are dealing with somebody who is in fact seriously ill, they absolutely would qualify for a MOLS, especially if they don't want a lot of unwanted things. And so really thinking about that. Also, they still need a durable power of attorney for health because the MOLS is very prescriptive about, resuscitation and those things. There sometimes are kind of gray areas, and having an agent, even in seriously ill people who may have other decisions made, is really, really important because at the end of the day, it's just not all black and white. So, we talked about all of these flavors, we talked about all these forms. What is the point and why do we care, right? So I think it's really important to note that more interventions and life-sustaining treatment has absolutely been associated with poor patient quality of life and higher family distress. Just because we can do things to people doesn't mean we should do things to people. And in a lot of cases, in these very seriously ill patients, it actually makes the families and patient suffer, right? So if you look at the Gallup poll, about 9 in 10 adults report that they want to die in their homes free of pain. Today, actually in 2004, 52% are still dying in institutions. So we are a long way from really achieving what patients and families say they want, which is death at home with their loved ones. 30% die after an intensive care unit stay in the last 3 months of life. So that's that. And many cancer patients receive chemo late in life. 12% were receiving chemo 2 weeks before they died. So we are still doing a lot of stuff to really sick patients. And if they did get chemo late, it was a 30% chance less that they would have any hospice. I mean, 2 weeks of hospice isn't much hospice, folks, but it's better than nothing, I guess. They had much higher rates of CPR, and they had much higher risk of being in and dying in the intensive care. And I think it's because people don't realize sometimes that where we are, if you will. So again, improved outcomes when people have advanced directives. 37% of cancer patients had discussed end-of-life issues with the physician an average of 4 months before death in this JAMA article, and they had better quality of life. They received less aggressive care near death. They were more likely to receive hospice care, and because of that, families had much better bereavement adjustment after the death of their loved one. So it really does matter. It makes a huge difference. Patients who reported having an end-of-life conversation were more likely to know that they were terminally ill. I was horrified when Rachel Bernanke published in 2014 a JAMA article that said that 68% of patients with metastatic lung cancer do not realize that their chemo that they are receiving is not curative. Metastatic lung cancer. About over half of them believe that they are going to be cured from it. 88% of metastatic colon cancer patients believe that they are going to be cured of their illness. We have got to do better about those chocolate conversations and helping people understand what they are up against. We're not doing a good job. So they report more peacefulness, they desired and received less invasive care when they really understood what was happening to them. And there was a randomized controlled trial for advanced care planning who showed that the people who had gotten advanced care planning and died were more likely to have their wishes known and followed, 86% versus 30%. So it really does matter. If we're doing this and filling out the right forms, we are having an impact. Also, really importantly, there is no increase in patient distress. I can't tell you the number of providers I talk to who say, oh, I don't want to take away their hope. But families agree that false hope is not an acceptable way to maintain hope. So if there really isn't hope for a cure, or there really isn't hope for whatever it is that we're hoping for, it's really important that they know so that they can plan. Evidence does not support the commonly held belief that communication about advanced care planning and end of life increasing depression, anxiety, or hopelessness. So I mean, that is well established in the literature that we are not doing harm by doing this. In fact, we are really helping patients and their families plan. Also, surrogates believe that having a realistic view allows them to support patients and each other better, right? If they know what they're up against, they can pull together as a family. But if we've got all these secrets and mom's got cancer but nobody knows, la 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 la, you guys know how that goes. It never goes well, right? Also, really importantly, families who get thrust into these decision-making roles without much planning or preparation really struggle. This is a really, really bad thing to happen, and it happens all the time. Somebody names their daughter as their surrogate, they never have a conversation, and that poor daughter, oh my God, I don't know what my mom would have wanted. And it really puts a tremendous burden on her to have to do that. So again, it's really uncommon for people to get all the way to the end of their life and maintain their capacity. Okay? In general, the majority of patients are going to end up with a surrogate decision maker, whether it's for years or a couple of days before they die. Study of older adults who required decisions to be made, 70% didn't have the capacity to make them at end of life. So there's going to be somebody who needs to step in. A third of these surrogates had long-lasting negative consequences. They do pull the plug on mom, right? And they really struggle with it. They feel stressed, they feel guilty about the decision, they doubt whether they made the right decision, and that eats at them, and it destroys families, right? It's one thing if everybody agrees, but if my brother really doesn't want to do this and I do it anyway and mom dies, we may never speak to each other again. And we see the carnage of this in hospice as we work with our bereaved families when they have been thrust into these decisions and they are not prepared. It's really, really interesting and sad. And when surrogates knew that this was what mom would have wanted, this would drastically reduce this negative impact. So another way to, when you start to have these conversations with patients, you can talk about this is a gift that you're giving your family so that they know what you want. And cite this, that it's so hard for families when this happens and nobody knows. This is not the reason I do my job every single day, but the other thing that's really important for us as a state to know is that this saves a pile of money, okay? A study looked at expense and end-of-life discussions. The costs were 35% lower in patients who reported having an end-of-life discussion. Again, they knew that they were sick, and most of the time when people know how sick they opt for less care. It's the margaritas on the beach, no more chemotherapy, thank you very much, right? But they have to be told because they don't just intuitively know. Palliative care, who often has these discussions, has been shown in multiple studies to decrease the cost. and increasing the practice of early end-of-life conversations has been proposed by experts as one of 5 key changes to bend the cost curve for oncology and other care. If we can have some of these conversations so that people can make informed choices about these very expensive modalities, some of them are still going to do them anyway, but many of them are going to say, no, thank you, I'm going to go home and spend time with my kids. So again, just as a shameless advertising, I want to again mention that as part of the SIM, Russ's group can help with some of this. So if you all want community-based educational sessions, physician-based education for providers and staff, and the Conversation Project community forums to help spread the word, especially in communities where this is forbidden, like the Latino community, et cetera. That is all part of this same grant that we are all sort of participating in with RIQI, who's doing this particular portion. And again, HopeHealth, we are running that 8-hour conversations thing, and it's fun. It really is. 8 hours. We really teach people a good format and a tool to have better conversations, not just with seriously ill adults, but really with any adult. Well, with any, actually not even adult, with any patient, really improving communication skills, but it's especially helpful when the stakes are high and you have to wade into these shark-infested waters, talking about end of life, talking about serious illness, talking about those things.